Hello, everyone. This talk today will focus on gynecologic care for transgender and non binary patients. At Valley Medical Center, a lot of our transgender and non binary patients end up receiving their health care at the Gender Health Clinic. But regardless, there are several OB-GYNs attendings within our department that will do hysterectomies for these patients. So, as residents, we are inevitably going to work with trans patients. And even for the attendings and residents that happen to not do these surgeries, it's still important that we know the basics as far as terminology, in terms of medical screening and medical treatments, specifically gender affirming treatments and the options available to these patients. ACOG actually released a committee opinion almost 10 years ago about the importance of OB-GYNs being prepared to assist or refer trans patients, again, for routine treatment and screening, as well as gender affirming therapies. This is extremely important because this is a minority population and this is also an oppressed population. In addition to the oppression they face from just systemic institutionalized transphobia in our society, they also are often underserved by the healthcare community, and it's often due to a lack of knowledge and awareness, whether it be just an ignorance regarding what a transgender identity means, or even ignorance regarding what hormonal and surgical treatments are available to them. That can also be a source of distress and essentially medical mistreatment. So it's very important that all of us are aware of how to assist these patients when they are seen in our clinic or on our inpatient services. I wanted to start with just some basics for terminology. The differences between sex and gender is very important. Um, Sex is essentially what we label an infant as when they're born. Sometimes it even starts with prenatal care. We get an ultrasound. You either see a penis or you don't see a penis. And so you say this is a boy or this is a girl. And then, of course, when they are born, you kind of verify that with external genitalia. And that's essentially how we assign an infant sex. Although this isn't like 100% accurate because you could be missing any kind of like chromosomal abnormalities. There could be other uh, intersex conditions that the infant has that makes it more difficult to label. This is typically how we define sex in our society, is basically having a penis or a vagina when you're born. Sometimes it's referred to, as birth sex, natal sex, biological sex, but the recommended term is sex assigned at birth. Gender is completely different. Gender is a social construct. It's something that we invented, but at the same time, along with other social constructs, it still has a large bearing on someone's identity, or most people's identity. Uh, in society, we usually define gender as a binary of a man or a woman. And so there are things, there are colors, there are clothing, there are smells that are considered masculine versus feminine. And we kind of expect people to fall in one of these two boxes, but it doesn't always work that way. I will get into non binary gender in a couple of slides, but basically, gender is how we as a society define people. And of course, people can fall anywhere along that spectrum in terms of their gender identity and gender expression. Transgender people are people whose sex assigned at birth does not correlate or match up with their gender identity. So, for example, I was assigned female at birth based on my genitalia. And if I now and when I was younger identified as male or masculine, I would be a trans man or a trans masculine individual. And the opposite is true. So if someone were assigned a male when they were born, but throughout their lives they've identified as female or feminine, that person would be identified as trans feminine or a trans woman. Um, Transgender is considered an umbrella term, so it includes all the terms listed below, but it also includes people that are that don't fit into the binary. So even if you're talking about someone that identifies as a trans man or a trans woman, those are kind of still identifying within this binary structure of man or woman, but there are people that don't identify as either or identify as both, and those people will be considered non-binary, but they still fall under the umbrella term as of trans most of the time. Again, more on people with non-binary gender identity. It is important to distinguish sexual orientation from gender identity. You cannot assume someone's orientation based on their based on their gender identity, or based on their gender period. So if someone is a trans woman, you can't assume that they are interested in dating men. That person can be a trans woman that dates women, or a trans woman that dates trans men. There's a spectrum on sexual orientation, just like there is with gender, and it doesn't always match up the way that you would expect it to, or society expects it to. Um, most of us know the terms lesbian and gay. Most of us know bisexual as well. There can be an overlap with pansexual, and so some people might identify and say, like, I'm bisexual, I'm attracted to cisgender men or cisgender women or men and women, but some people might identify as pansexual and say that I am attracted to all genders. So I would date someone that's gender non-binary. I would date someone that was a trans man. I would date a cis woman. And sometimes bisexual people will also identify as pansexual. So it's just a matter of, obviously, if it's clinically relevant, distinguishing what their exact definition is of their sexual orientation. People that are asexual often experience little to no sexual attraction to others. They may still engage in sexual activity as part of, intimate relationships, but that doesn't mean that they are necessarily having as much enjoyment or fulfillment of it as other people. And not to be mistaken, asexual people can still have romantic and intimate relationships. They just may not feel sexual arousal or attraction to the person that they are romantically involved or interested in. Queer is another umbrella term for anybody who basically feels as though their sexual orientation or gender identity falls outside of what the societal norm is. So for society, what's considered normal or considered a norm is to be a cisgender heterosexual person. So what's considered normal in society, and has been for many, many years, is to be someone whose sex assigned at birth correlates with their gender identity, and you're supposed to date someone of the opposite sex and gender, essentially. But queer is anybody that doesn't fall into that very strict category of what society kind of imposes on us. Queer has been historically used as a slur, but it's been reclaimed by many as a term of empowerment. However, of course, there are still people that find the term offensive. When in doubt, you can just ask a person what their orientation is, what their identity is, and just stick with their own terminology for how they describe themselves. Just a point on outdated terminology. These are terms that used to be said, and language along with society and culture is ever evolving, and so who knows, in like 10 years everything I may be saying right now could be untrue. But that's the point about, we always say medicine, we're lifelong learners, and so you always want to stay up to date, and there are some great resources for staying up to date that I will include at the end of this presentation. And so in terms of outdated terminology, biological female or male is outdated. Just say assign female or male at birth, because essentially, I guess we assign it based on your genitalia, and that does obviously have correlation with biological physiology and anatomy that's going on, but it's not exactly that precise. It's just kind of, we look and we decide and we go from there, and so it's not completely accurate to say it's biological. Cross-sex hormone therapy, again, it's more gender affirming hormone therapy. Female to male and male to female is a term that's been used often, especially like in the medical field, to be, I guess, more clear to people that have a lack of an understanding regarding the identity. But essentially, if I was a trans woman, chances are for most of my life I've identified as a girl or as a woman, regardless of what, my anatomy was or what people perceive me to be. I have identified as a woman. So to say I used to be a man would not make sense. I was never a man. I was always a woman. My anatomy or my sex assigned at birth may have been male, but I've always identified as a woman. So for a lot of people, it could be offensive to be like, "Oh, they used to be a man." That's inaccurate. So trans man and trans woman. Gender nonconforming, preferred term now is gender non-binary. And again, it's kind of like when we call a patient non-compliant, it's kind of labeling them as you refuse to conform, as if it's almost a negative. So just more accurate term would be non-binary. Homosexual has historical context in it where the DSM used to label it as a mental health disorder, and then some people also use it as a slur or as having a negative connotation. So again, just be accurate: gay, lesbian, bisexual, pansexual, etc. Legal name, you again, to be more accurate, what is the name on your legal documents, or what is the administrative name on most of your paperwork or your license, etc. And preferred name. So a lot of trans people, when they transition, will pick a name that is more in line with their gender identity. And so, say if I was a trans man, that means I was assigned a female at birth, so my parents may have named me Brittany or Jessica. But if I am identifying as male, and I may want to change my name to a more male identifying or, stereotypically masculine name. So I might change it to Joe or, I don't know, Harry, whatever the case may be. And that can be to make it identify with your own identity more, as well as to prevent you from being outed in society. So just say chosen name instead of preferred name, because it's not a preference. Like my name is Joseph now. I don't necessarily prefer you to call me this over Jessica. I don't want to be called Jessica. My name is Joseph. So that's your chosen name, that's your name used. Similar with pronouns. It's not necessarily like a preference. Like if I'm a trans man, I don't want you calling me she and her. I may want you to call me he and his or other pronouns. But regardless, preferred just has a kind of an odd connotation to it, as if there are like options when this person likely has their own pronouns and name that they identify with and that you should be calling them. Sex change, sex reassignment, gender reconstruction. It's also inaccurate. As I discussed before, sex is often something that's like reassigned at birth, and we're not necessarily like changing that. We're just doing treatments and procedures to oftentimes adjust your physical characteristics to be in line with your gender identities to as not be causing dysphoria. So it's not really we're reassigning or we're changing your sex or reconstruction. It's just gender affirming surgery, the same way a lot of hormonal treatments would be called gender affirming hormone treatment. Sexual preference or lifestyle, also inaccurate. Sexual orientation. People often refer to sexual orientation as if it's a choice, and kind of preference and lifestyle reinforces that inaccuracy, and so it's just orientation. And then transgendered is also inaccurate grammatically and otherwise, so just a transgender person. It's important in any talk about trans identities to discuss the term gender dysphoria. So this is a term that's in the DSM-5, and its criteria is listed below. So the DSM-5 calls gender dysphoria to be an incongruence between one's experienced gender and assigned gender. of at least 6 months and manifested by at least two of the following. So, again, an incongruence between their sex characteristics and their gender, a strong desire to be rid of one's sex characteristics because of this incongruence, a strong desire for the sex characteristics of the other gender, and a strong desire to be of the other gender and to be treated of the other gender. Um, and then, in addition to this, it's supposed to be associated with clinically significant distress or impairment in social, occupational, or other areas of functioning. This is controversial. For one, if you have been paying attention to what we've been talking about for the past minutes, it is it's saying, I guess it's saying one's expressed gender versus their assigned gender, and it's not even talking about sex necessarily. So the language could be better. And then also, it's controversial in the fact that if it's basically saying if a transgender person is experiencing distress in their social settings, in their work settings, in their educational settings, it qualifies them for a mental health disorder. Um, and the truth of the matter is, many trans people aren't necessarily just experiencing this distress because they're mentally ill. They're experiencing it because of society, because society tells them that, they are wrong, to identify with the gender that they do if it doesn't match up completely with their sex. And society also tells them that, they're wrong to even express that gender identity if it doesn't match up with what society wants them to do. And so that's what's causing distress for a lot of people. And so and it's almost inevitable that you're going to experience that as a trans person in this world. So it's problematic in a sense that it's saying, oh, you are experiencing distress because of your discrimination. You are now labeled as mentally ill. Um, Hopefully, in years to come, it will change. Um, DSM used to label homosexuality as a mental health disorder. So hopefully, with time, this will change. But another important note, I didn't have a slide for this, but a lot of um, health insurance plans and other medical societies and organizations require someone to be labeled with gender dysphoria in order to receive gender affirming hormonal and surgical therapies, which is also problematic because why can't I just be a trans person that wants to take testosterone to masculinize myself and not have to be labeled as being mentally ill or have a mental health diagnosis in order to do so? That could be a whole another talk, but it's just very important to know about that controversy, in terms of the gatekeeping that we do, the gatekeeping that is set up against trans people when they're seeking hormonal surgical treatments, etc. Um, in terms of demographics, it's estimated that about 0.3% of all adults are trans, which would equal about 9 million people in this country. In terms of disparities, like I've mentioned before, trans people are more likely to experience job and housing discrimination, um, and difficulty accessing healthcare because of these two issues, and also discrimination in the healthcare setting when they do get healthcare. So, a lot of trans people are less likely to receive the appropriate screenings in terms of indicated breast exams, pap smears, STI screening, and this is often due to obviously on it's twofold. On one half, it's because maybe they don't have health insurance because they've been discriminated against in terms of like hiring practices. But then when they do get in a healthcare setting, a lot of the rest of it is related to provider ignorance on what screenings they should be offering these patients, or just provider transphobia, and that's why they're not offering these screenings. Oftentimes, trans people may have higher rates of substance abuse and mental health disorders. And that I'm not referring to gender dysphoria, I'm referring to depression, anxiety, etc. And it's important to note that many minority populations deal with this, and it's not because being a minority is in and of itself a predisposition to having a mental health disorder. It's basically because of what minorities deal with in society. They can often have higher rates of depression, anxiety, and substance use to help cope with this depression and anxiety. In terms of hate crimes, of course, they're very likely to be victims of hate crimes, unfortunately. In 2019, at least 27 trans or non binary people were murdered. 91% of them were black trans women. In this year, 2020, 11 black trans women were killed. And I actually made this, this is from September, so by the time the year ends, the number will likely be higher. And about half of these women were found in a 1 week period murdered. Intersectionality is something that's important to talk about whenever you're talking about any identity, especially minority identities. And so, like I've mentioned with black trans women, being trans, being a woman in this world is challenging. Being a trans woman is even harder. And then when you add in being African American, being a black trans woman, the oppression just kind of stacks up on itself. I wanted to take a moment to discuss the black respondents in the National Transgender Discrimination Survey. It found that black trans people had an extremely high unemployment rate of about 25%, which is twice the rate of the overall sample of trans people and 4 times the rate of the general population. About 40% of black trans respondents in the survey had experienced homelessness at some point in their lives, which is 5 times the rate of the U.S. population. They also noted that about 30% or a third of them were living in extreme poverty, making less than $10,000 per year. This is twice the rate of all trans people, 4 times the rate of black people, and 8 times the rate of the general U.S. population. So again, it kind of just multiplies on itself. And then about a fifth of them were living with HIV, which again is 8 times the rate of trans people of all races, 8 times the rate of black people of all gender identities, and about 34 times the rate of the U.S. population. Half of them who attended school experienced harassment if they were expressing their identity or gender nonconformity, or excuse me, I should say, if they were gender non-binary and expressing their gender identity, they reported facing harassment. I directly quoted this from the survey, and that terminology is outdated now, so excuse me. Half of them reported having attempted suicide. And one positive note, many of them who were out to their families did say that their family structure and support was as strong as before they came out. And this was actually better than the overall sample of transgender respondents in terms of how they labeled their family support and structure before and after coming out. We will now talk about transitioning. There are multiple and many ways to transition. Essentially, transitioning is when a trans person decides to start expressing their gender identity, and this can be assisted with hormones. This can be surgical, and it can also be non-medical. So we'll start with non-medical because it's often how a lot of trans people start transitioning. So there are things, say if I identified as male, I might start changing my clothing and my hair, my behavior, my voice, and my speech patterns to be more masculine. And then I might also start informing people of my pronouns and my name, whether they be he, him, and his, or otherwise, or whether my new name is Alex or something less feminine. And then oftentimes people will change their legal documents too, essentially to make sure that their license and their passport doesn't say a gender that they don't identify with. Other non-medical means of transitioning and I guess I should note that I am going to focus on trans masculine
patients and trans men, because as OB-GYNs, that's mostly who our patients, if we have trans patients in our clinic, that's mostly who they'll be, is in our clinic, we're basically probably going to get all people who were assigned female at birth. And so if we are seeing trans patients in our clinic, they're likely going to be either gender non-binary or masculine in terms of their gender expression or identity. And so, for a lot of trans men and trans masculine individuals, they may do breast binding, and that's again as they're changing their appearance and their gender expression to the outside world. They may not want to be walking around with obvious breasts. The risk to this is that, especially depending on how they bind, it can cause breast pain. It can also cause skin irritations and fungal infections just from kind of having like a warm, damp environment if you're using certain types of binders. And there's one type of binder that's shown above that's kind of like a kind of tight sports bra. Some people may also use tape or ace bandages, so it's just important to know how they're binding and if it's causing any kind of medical issues, and then kind of adjust from there. Um, a lot of trans men will do something called packing, which is essentially creating the illusion of a penis. And this can be important for one, for their identity, especially if they desire to have a penis. And then also in terms of passing or blending in with other men, it can be important. So if they're in the gym or wearing any kind of other kind of tight clothing, they may want that bulge to be there so people are less likely to question their gender, especially in a public setting if they're not out. A lot of them may use stand to pee devices. Essentially, this is kind of like a prosthetic penis that they can use to pack, but also use to pee through. It's kind of like a little funnel with a urethra at the end. And again, this can be important for your gender identity, especially if you desire to have a penis. And it can also be important for passing again, because if you're a trans man using a male's bathroom, there's only like a urinal available, or you just have to stand to pee for whatever reason, that can be important to have that device. And a lot of these things they can buy online at different websites that are specifically designed for trans people. In terms of surgical treatments for trans masculine or trans men, um, there is masculinizing chest surgery. So again, we talked about binding before, but a more of a permanent solution would be to do this masculinizing chest surgery. So it removes a lot of the breast tissue and just reconstructs the chest to be more masculine. This is often done by plastic general surgeons. There is a variety of things that you can do for bottom surgery. A lot of us will do hysterectomy, oophorectomy for a lot of these patients, and because for a lot of them, obviously the ovaries are a source of estrogen, which for a lot of them they may not want estrogen, or at least that level of estrogen. And then also in terms of a hysterectomy, that can be important too, because for a lot of people, having a period causes a significant amount of dysphoria. I'll get into family planning later, but sometimes we do preserve at least one or both eggs should they desire to use this for family planning in the future. In terms of other bottom surgery, there are a variety of kind of cosmetic procedures to create essentially a penis and get rid of the vagina. There are also cosmetic procedures to essentially make I guess, testicles or scrotum. They aren't functioning, obviously, but it's for the appearance. Metoidioplasty is a little bit different from phalloplasty, and that could also be a whole other lecture on surgical treatments. But essentially, for metoidioplasty, oftentimes they will take testosterone to enlarge the clitoris, and then there can be a surgery to give them a functioning but small penis with essentially the clitoris used as the glands of the penis. But there's also phalloplasty, which makes a more larger or slash realistic appearing penis, but it may not be as functional or as sensitive in the same way as if you were to just use your clitoral tissue as the glands. Um, in terms of gender affirming hormone therapies, um, the goal of masculinizing hormone therapy is to minimize all of the feminine secondary sex characteristics and develop more male secondary sex characteristics. So, what you expect when you place a trans person or as any person on testosterone, you would expect them to have more facial and body hair, deepening of the voice, redistribution of facial and body fat, increased muscle mass. They may sweat more, have more odor when they sweat, and you also expect some hairline recession as well. For a lot of people that are on testosterone, their libido may be increased. A lot of times you'll experience growth in their clitoris, along with vaginal dryness and cessation of their menses. And then there's also a variety of emotional and social changes that they can experience like anybody else that's taking any kind of hormonal therapy. So with testosterone, obviously you have increased testosterone levels. Um, and you have decreased estradiol levels, about to the level that a lot of cis men have in their bloodstream. There are different ways of administration, including injections, gel, cream, patches. In terms of monitoring for side effects, oftentimes you'll use a CBC to make sure that they're not having too much production, like erythropoiesis essentially. You'll monitor their total testosterone, and you might also monitor their sex hormone binding globulin. There is no evidence of increased risks of gynecologic malignancies with testosterone. This used to be thought that it could be a side effect because we know, like in a lot of people with PCOS, it kind of can um, affect the ovaries in a way that we worry about higher risk of ovarian cancer, etc. But this hasn't been shown to be true. Um, Again, more detailed with the side effects. A lot of them within 6 months will stop having periods, and this often comes from, again, suppression of ovulation as well as endometrial atrophy. Again, a lot of them will have these cystic changes in their ovaries, similar to PCOS, but without an increased risk of ovarian cancer. And a lot of them may have abnormal uterine bleeding. Treatments for this, you can always give progesterone in terms of like an IUD or Depo, etc. Other treatments could be endometrial ablation or just a hysterectomy. For a lot of people, testosterone will cause vaginal atrophy, which can lead to, atrophic vaginitis, especially with they can have high rates of bacterial vaginosis. And like other people that have, vaginal atrophy, it can lead to cystitis, cervicitis, and dyspareunia. Again, you should not be assuming that because someone is a trans man on testosterone that they are not having any kind of vaginal penetration or intercourse. And so if they are and it's causing pain for them, they can use different lubricants or moisturizers, and they can also use vaginal estrogen to treat the atrophy. A lot of people, and it's not really clear why, may have post administration cramping. So after they administer their testosterone, may have like essentially like uterine like menstrual cramps that can be very painful. Um, we're not really sure why this happens or what the best treatment for it is, besides like NSAIDs and heating pads. Like we recommend other people that have menstrual cramps, but for a lot of these people, obviously having a hysterectomy will get rid of this cramping. Um, with testosterone, there is a possible increased risk of polycythemia. I think I mentioned on the prior slide about monitoring them with CBCs. There's also a risk of hypertension and hyperlipidemia. It's again unclear, theoretically, with all of these increased risks, you would suspect a possible increased risk of morbidity and mortality, but it's unclear thus far. And that's in large part because we have not been offering these hormonal therapies for that long to that many people, and it often hasn't been researched enough. So I'm sure with coming years we'll learn more about the long-term effects of testosterone. In terms of going back to just there is no recommended surgical approach specifically for trans men. As we know, ACOG says that if it's feasible and safe, that a vaginal hysterectomy is the least invasive, so that's what recommended for all people. The advantage for this, of course, is for a lot of trans men, you won't have any kind of abdominal scars that may out you to people. But also, you have to consider the fact that a lot of them may have vaginal atrophy and may have tight introituses, which may make that surgery more technically challenging. Um, some people, if they don't have a desire for vaginal penetration and no plans for future genital reconstructive surgery, you could consider a colpochlesis. But again, this is only if they don't have plans for future surgery, because for some people that get metoidioplasty or phalloplasty, the surgeon may desire to use their vaginal mucosa for this, which you won't necessarily be able to access after you do a colpochlesis. In terms of atrophy, again, there's limited research in regarding trans men and hysterectomy and surgical approaches, preoperative planning regarding their atrophy and the utility of using preoperative vaginal estrogen. So it can just be kind of a discussion with your patient whether you think that may be helpful for them for their surgery and post-op care or not. So just shared decision making from that perspective. And I mentioned before that some people desire oophorectomy. However, some people may want to preserve one or both ovaries for future fertility. Um, and then we know that for a lot of cisgender, or for a lot of our patients that we remove their ovaries and they're not on any kind of hormonal treatment, especially that they can have increased cardiovascular risks similar to that of, essentially early menopause. It's unknown for patients that are taking testosterone if these risks are the same or better or worse, but we just need more research and evidence to guide us in that direction so we can properly counsel them on the risks of removing both ovaries. Slide about sexual health and family planning. Again, don't assume their sexual practices and partners. Just because someone is a trans man doesn't mean they're not having vaginal penetrative intercourse. It's important with every patient that we see to discuss sex practices and the risk of pregnancy as well as contraception. So obviously, if they're not doing any kind of vaginal intercourse, the risk of pregnancy is very, very low. But if they are and they don't want to be pregnant, then contraception is an important thing to talk about. Testosterone, although many people may feel like, oh, okay, it's causing endometrial atrophy, it's causing, my periods to stop, it's causing me not to ovulate. It's not 100%, so it's not a reliable form of contraception, and it's also teratogenic if you were to get pregnant. So it's important that if you are having vaginal penetrative intercourse with a partner that is ejaculating into the vagina and you have a uterus, then you need to be contracepting. We do know that emergency contraception is not inhibited by testosterone use, so they can still have access to all the other forms of emergency contraception that we offer our patients who are not on testosterone. Again, because some of them may want to preserve their ovaries for future pregnancies or family planning. We don't know the effects of prolonged testosterone on ovarian function, so that's just an important point to counsel them about. It may be worth them freezing, if they can afford to, freezing their ovaries, freezing embryos, freezing ovarian tissue if they plan on being on testosterone for a long time before trying to use their eggs. Last point here, but possibly the most very important for us in clinic. It's important to use a gender affirming approach to any kind of any encounter that you have with a trans person, but especially in clinic when we're talking about history taking and physical exams. So it's important, like I said before, to take a thorough history. You want to know if they're on hormones, what kind of how they're administering them, who's monitoring them, if they've had any kind of surgical gender affirming treatment in the past. Obviously, we talked about the importance of taking a sexual history regarding their sexual practices and partners. We know that trans people are likely to have had negative experiences with the healthcare system in the past. So they're already kind of coming in often with a lot of hesitation and anxiety regarding this. And so we should do everything that we can to make this experience better than their past experiences, to kind of relieve some of those fears and concerns. For a lot of them, the pelvic exam can cause a lot of anxiety and dysphoria as well. So again, using the gender affirming approach, even before the pelvic exam, you want to make sure you're using the person's correct names and pronouns. Some trans people may have preferred terminology for their genitalia and organs, so some trans men may not want you to call it a vagina or a clitoris, etc. So you should just check in with each time you do the physical exam just to be like, hey, do you have any preferred terms that you want me to call your anatomy, your genitalia, so you can be accurate and respectful. And only examine what is necessary. So if someone's coming in for like breast pain, there you shouldn't just be doing a pelvic exam because you're curious. And that sounds kind of obvious, but for a lot of people, if they know a trans person is on testosterone or had this surgery or that surgery, they may be curious. And it does happen that people do these exams that are unnecessary for that reason, and that can also be a source of trauma to a lot of patients. So don't do that. Only do the exam that is absolutely necessary. Um, when you're doing the physical exams, it's important to discuss the components of the exam that you're going to do beforehand. I often will check in with patients that are more nervous regarding the exam and ask them, do you want me to say everything before I do it while I'm doing it, or do you want me to just say nothing at all and just go? So again, in this population, because of the trauma that they've often experienced with physical exams or the dysphoria that they've experienced with the physical exam, it's even more important to kind of check in and see how you can make this exam as, least traumatic as possible. You could also consider giving an anxiolytic before the exam. Um, and you could also consider giving vaginal estrogen for 1 to 2 weeks before a planned exam, because we know that atrophy can make these exams more painful. For a lot of patients, they can, this is even for our non-trans patients, there's an option to self-collect the swab. So if you're doing a blind vaginal swab for BV or gonorrhea, they can sometimes collect them themselves, and that may be less traumatic than you doing it with a speculum. For pap smears, again, because of the atrophy caused by patients that are caused by testosterone, it's important to know that and to note that on the pap smear collection, because there's a higher risk of inadequate sampling. That's just something to be aware of. And then also sometimes if the lab sees that the person's name and pronouns are masculine, they get a pap smear sample, they may assume that it's either an anal pap, or they may assume that it was mislabeled and they'll discard it. So make sure when you're doing a pap and you're sending it down that you just kind of put in the little notes that it was done either on, someone that's trans, it's a cervical pap, indicated they're on testosterone, etc. Because obviously, luckily for us in the PAP collection, it asks like, are they having abnormal bleeding? Are they on hormonal therapy? So that's a perfect point to indicate that in the EMR. In terms of our patients that will need ultrasounds, try to do a transabdominal if feasible, because again, the transvaginal can cause significant dysphoria and anxiety. If a transvaginal is necessary or indicated, you can again consider giving them some kind of benzo before the exam, and you can also consider using vaginal and vulvar lidocaine. And again, like above, you can consider using vaginal estrogen before they are going to have this vaginal probe, vaginal ultrasound. Finally, just a final slide on where you can get further education and find more resources. There are a million different websites online to learn about terminology or the experiences of trans people or transgender people's health disparities. But these are some of the most used and, I guess you could say, reputable ones for us as healthcare providers. And just to point down below that it should never be the burden of the minority to educate the majority. Oftentimes, minority populations are oppressed and being discriminated against and going through enough without also having to explain their lives and their pronouns and their gender and the definitions and terminology to the majority. No, it shouldn't be the case that a patient is having to educate their doctor or healthcare provider about how to give them proper medical treatment. We should be doing the work on our own. So please visit several or all of these websites if you have any questions or regarding this presentation or regarding any patients that you have or will have in the future. All right. Thanks, everyone.